So I would appreciate your indulgence with any advice that you might have regarding this case. This is a 28-year-old woman with a history of diabetes, hypertension, polycystic ovarian syndrome, and also old stroke that I'll get into in the end. She presented initially with agitation and combativeness at home, and actually was triaged to the psych ER initially. But then she became unresponsive and endured a seizure. She had right gaze preference with a right-sided weakness, and then subsequently deteriorated. She desaturated and required intubation and was in the ICU for a while. She was found to have bilateral PEs and started on heparin. Delirium, workup, and hypercoagulable workup were negative. So as you can see from this CAT scan, initially there's a mixture of new and old infarcts. The old one being predominantly on the right side, and the newer ones that you'll see on the MRI on the left, MCA. So this is her MRI showing subacute infarcts on the left, MCA and PCA territories. The MRA showed bilateral stenosis worse on the left side. As you can see there, her hypercoagulable panel was predominantly negative. The main thing was an elevated SED rate of 132, and also we did an LP on this patient, and it didn't reveal any pathology. This is her conventional diagnostic angiogram. I apologize, I don't have adequate imaging of the left side, but this is primarily the right side showing stenosis and inclusion of the ICA from the ophthalmic segment all the way to the climal segment, with revascularization and collateralization of flow suggestive of moya-moya pattern. So she actually underwent ECA-ICA bypass, and I'm sorry, I don't have equivalent conventional angiogram imaging. This was just done last week. So this is a CT angiogram reconstruction, obviously, showing the bilateral bypasses. I just wanted to present this case to ask, well, first of all, I need to mention regarding her past history of stroke. She was found at about age 15 to have had old strokes, and she had diagnostic imaging at the time that was also suggestive of moya-moya. And for whatever reason, she was not operated upon, or there was no intervention performed at that time. So my questions to you are, first of all, is there any role for stenting or stenting versus neurosurgical intervention, and with the time course in terms of this being her second event now, make any difference in whether or not to go ahead with intervention?
What was her ethnicity, and did she have any other metabolic disorder, Down syndrome?
She did not. Yeah, she's African American, and as far as I know, she did not have any.
What was the reason for the elevated SED rate?
I don't think we adequately determined that. That was the only thing in the lab that we really found to be positive. She actually went through 3 series of hypercoagulable workups, and they were all basically points in the way for the SED rates.
And SBE workup was negative?
Yeah. I can take up with that one first.
Any takers in the audience for endovascular approach?
It is a little odd because usually children present with infarcts, and as you get older and you establish a region parabola, present with hemorrhages. And I guess she had been symptomatic with infarcts in childhood and now on into adulthood with nothing that was a risk factor other than the traditional risk factors for atherosclerotic disease in locations as opposed to more distal moya location.
One thing that doesn't fit in her imaging is that she has MCA and PCA infarcts, right? And if you look at her angiogram, her P1s, PCAs are originating off the basement, right? So you don't have fetal origin to explain that occlusion of the carotid artery produced both posterior and anterior circulation infarct. Her carotid condition could be pre-existing, but the SED rate, I think, is a clue you need to have a really good workup. There is something else going on. She is not truly hypercoagulable, but there is something else going on. And the carditis would have been a little bit more easy, and probably she would have had some hemorrhagic conversion. But the differential risk is very broad. And the other thing to mention is, I hate to bring this up, but right to left shunt, did you look into that?
I was not privy to that discussion, but she did have a TE that was negative. So,
With bubble?
I'm not sure.
I think you may have measles and a broken leg, basically two things going on, not necessarily.
Yeah, I would have to agree with the other speaker, the other commentators on that regard, because usually the patients with moyas stutter along chronically, and when something triggers them, it may not necessarily be the vasculopathic process itself. And then sometimes all the efforts to treat that cerebrovasculopathy accelerate the disease itself. So there may be something to that SED rate.
Did this patient have sickle cell disease?
As far as I know, she did. She was tested for it.
She was tested?
Question was sickle cell disease.
Yeah.
And the bypasses were done simultaneously?
They were.
What was the outcome after the bypass?
She is basically stable. Not changed pretty much. She follows simple commands, but she doesn't follow two-step commands.
Does anybody disagree with the decision to bypass?
Simultaneously?
Okay, disagree with one or both? You?
I think doing it simultaneously is a little bit risky. I certainly, you could debate the issue about bypass or EDAS or however you wanted to treat in someone who's acute, whether you ought to wait, but I think doing them at the same time risks bilateral hemorrhagic conversion of an unstable situation, in which case pathologists are going to make a diagnosis.
Thank you. I think there was one more speaker that we were trying to coordinate getting to talk, so if you want to, Dr. Abreu, I don't know if your talk is ready to go, you can do that with the audio vision. We can take the last comment while they're setting up the next talk.
Did you want to make a comment? Okay.